Okay, good afternoon, everybody. Thank you for coming to our session today. Today we have Paul Christos, and his presentation will be on how to communicate with a biostatistician when performing clinical research. Dr. Christos is an associate research professor of healthcare policy and research who received his doctorate in public health and epidemiology in 2009, a master's in biostatistics and master's in epidemiology in 1995, all from New York Medical College School of Public Health. Prior to joining Weill Cornell Medical College in January 2000, Dr. Christos worked as a biostatistician and epidemiologist at Strang Cancer Prevention Center, and later as a biostatistician in the dermatology service at Memorial Sloan Kettering Cancer Center. During that time, he also served as an adjunct faculty member in the Department of Public Health at Weill Cornell Medical College and in the Department of Health Quantitative Sciences at New York Medical College, where he taught introductory epidemiology and biostatistics to medical and graduate students. Dr. Christos is the director of the Research Design and Biostatistics Core, RDBC, of the CTSC. In this role, he directs the administrative structure of the RDBC in addition to his ongoing CTSC responsibilities of developing, organizing, evaluating, and teaching courses, mentoring junior investigators in writing protocols and proposals, reviewing protocols, developing new statistical methods applicable to translational science, providing analysis of data for projects through the RDBC, and participating in the National Biostatistics, Epidemiology, and Research Design BRD Consortium. He is also the lead biostatistician of 2 clinical study evaluation committees of the Weill Cornell Joint Clinical Trials Office, as well as the lead biostatistician on the Adult and Pediatric Translational Research Advisory Committees of the CTSC. So without further ado, the next voice you will hear is Paul Christos. Thank you.
Hi, thanks Agnes, for the introduction. And just to clarify, the RDBC was actually renamed. It's called now Biostatistics, Epidemiology, and Research Design, which is BIRD. So that's the core. Well, many CTSCs across the country have obviously different cores, and the biostatistics core tends to be one of them. And they're uniformly called BIRD, Biostatistics, Epidemiology, and Research Design. So I direct, as Agnes was saying, I direct that core for Weill Cornell. And we work with many researchers across many different clinical departments, helping them with their research studies, a lot of statistical analyses and things like that. So what I want to do today really is just talk about how to interact or communicate with a biostatistician, meaning that if you were to do a clinical research study, how would you actually interact with the statistician? When do you bring them in? We'll kind of talk about some of those things and the types of things they would need from you or from the clinician to help carry out the study. So R.A. Fisher was a famous statistician a number of years ago. He had a great quote, to call on the statistician after the experiment is done, maybe no more than asking him or her to perform a postmortem examination. They may be able to say what the experiment actually died of. So in other words, it's always good to bring in a statistician early when you're designing a research study. Many investigators will come to the statistician after the fact, after the data has already been collected. And if you have a really poor study design or things are not collected properly, it can really destroy the research study. So it's always good, ideally, to involve the statistician early on during the design phase of the study. So typically, when you're meeting with a biostatistician, if you, let's say you're an investigator carrying out a research study, and you're sitting down for the first time with a statistician early on, these are some of the tips that you would use to kind of interact with the statistician. Number one, do you have a study protocol? Presumably you would have something already drafted. What types of measurement instruments will you be using? So is it a quality of life study where you'll have quality of life instruments, or is it a study looking at depression, for example, where you'll have instruments to measure depression? You want to have all those kind of in hand when you're meeting with the statistician. What's the relevant background literature on the topic that you're studying? Do you have any existing data sets? Meaning, have you already collected some data on the subject that you're looking at? So typically the statistician will not be an expert in the clinical area. So statisticians are obviously trained in biostatistics, but they can work in many different health areas. So they're not really going to be well versed in necessarily cardiology or ophthalmology. Whatever you might be specifically studying, you can't expect them to know all the terms, basically. So you really want to start with a discussion in layperson terms when you're meeting with a statistician. Don't assume they would know exactly what you're measuring or what the disease is actually about. So typically a statistician, depending on the setup of how we have it in the department, a statistician might be assigned to work with one clinical department, like neurology, radiology, for example, where they kind of get well versed in that area over time, and they become very familiar with the different types of lingo for those, radiology projects, for example. Other times, like with the CTSC, we work on many different projects for many different investigators. So it could span many different clinical areas. That wouldn't necessarily be the case. But ideally, we'd like to have the statisticians have at least 30% effort, 40% effort working with one department, clinical department, so they can kind of become an expert in that area, know that field very specifically. So it's good to be patient. The statistician typically will ask a lot of questions early on. Common questions the clinician might ask would be, how many patients do I need in the study, which we'll talk about. How do I measure my endpoint of interest, which we'll talk about. So again, you want to avoid a lot of technical terminology. Just going to kind of break it down in terms of what is your primary objective of the study. Typically, it's good to have only one or two study aims. You'll see many grants, when you're reviewing grants, we'll have like aim 1, aim 2, aim 3, aim 4. It's really better to really only have one or two primary aims. So that really can kind of hone in the study and make it more organized. So when we have a research question, typically when we're designing the research protocol from the beginning, these are just some common terms to be aware of. So, what is your exposure of interest? What's the risk factor or the treatment that you're looking at? What is the primary outcome? Are you looking at the incidence of heart disease, lung cancer, whatever a very specific defined outcome? And then what's the population you're studying? Who meets the inclusion criteria for your study population? So really the basic question is X associated with a change in Y in population P? So X tends to be your risk factor or your exposure or your treatment. And then Y is your outcome. If it's a clinical trial and your goal is to lower blood pressure, for example, with a new treatment, Y would be blood pressure. You reduce it over time in a certain population. Is your population just diabetics? Are they hypertensive? What is the inclusion criteria for that population? They say the research question should also be SMART, the acronym SMART. So specifically, specific, meaning that you have one primary objective, ideally. Is it measurable? Is there a quantifiable endpoint? So if you're looking at a new treatment to lower blood pressure, your endpoint is going to be blood pressure. It might be blood pressure just continuous, where you just measure their actual blood pressure, let's say 6 months after they start the treatment. Or it might be an endpoint that's more categorical. Like, did you reduce their blood pressure below 140, for example? So you have to define that endpoint up front. Is it attainable? Do you actually have the appropriate resources in-house to carry out the study? Is it multi-center? Is it a single center? The CTSC, for example, has a lot of patient care resources available to help conduct studies. Is it relevant? Is it novel? Is it a new kind of concept? Is it clinically meaningful? What kind of reduction in blood pressure are you looking for? What would be a clinically meaningful difference if the new drug could reduce your blood pressure compared to, say, a standard drug? Is that difference clinically meaningful? Is it timely? How long will it take to collect data? Are you doing a cohort study, which tends to follow patients for many, many years or months? Or is it a more cross-sectional study where you're just kind of collecting data, or you're looking at a data repository where the data is already there for you to look? If anyone has any questions, just feel free to jump in. So in terms of a research question, a bad research question, when we say bad, we're talking about is very vague, unfocused. It's not really quantifiable. It may not even be feasible. Whereas a good research question, again, very focused, very specific, and we'll see some examples in a second. And it adds novelty to the subject. Here's an example. A bad research question, you wouldn't want to write this as your main question in a protocol. It was radiation therapy helpful or harmful? Obviously, that's too general of a question. So when you're doing clinical research, everything has to be really well defined. So the good research question in that setting would be, is there a difference in overall survival between stage 3A non-small cell lung cancer patients who receive postoperative radiotherapy versus those who did not receive postoperative radiotherapy? So you're really defining it. So the outcome here is overall survival, meaning how long did the patient survive post-treatment. The population of interest, very specific, stage 3A non-small cell lung cancer. So you're making a very specific population you're looking at. And then they're receiving either a treatment A or not, or B. So either they had the radiotherapy versus those who didn't receive it. Maybe they received something else. So you can kind of see they're probably going to compare two groups, those who got it versus those who didn't. And they have a very specific outcome. And the results will be generalizable just to this population of interest, those that have stage 3A. We're not necessarily looking at all of the types of stage for lung cancer. You could, but this is a much more focused research question. Whereas the one above is very general, that you can't really quantify the sentence of. Then typically when you're doing your study, what are you measuring in terms of the variables you're looking at? So we think of it as terms of outcomes and exposures. So is your outcome continuous? Meaning if your outcome is blood pressure, are you going to just look at it in terms of an absolute value? Is it ordinal? Sometimes an outcome might be like a quality of life instrument or like a depression score, but it might be categories like a Likert scale, 1, 2, 3, 4, or 5. So that's like an ordinal variable where they're answering a question on the survey, but it's an ordinal variable, so it's not truly continuous. Nominal meaning like is it binary or categorical, depending on like a pain score that's just considered mild, moderate, severe. And then what are other variables you want to measure when you do your study that might cause you problems? So a confounder basically is another type of variable that kind of gets in the way of the research question you're measuring. So if you're interested in, does exercise reduce your risk of colon cancer, for example? A potential confounder that you want to measure would be smoking, alcohol consumption, other things that might be related to exercise, that might be related to colon cancer would be a definition of confounder. So that typically comes from the literature. So you'll want to collect as much information on those variables as possible. Common confounders are like age, gender, race, ethnicity, basic demographic variables, comorbidities, other variables that you think might be important to measure. Ideally, your study is focusing on one specific risk factor, one outcome, or one treatment, one outcome. But these other variables are things you want to consider, so you need to measure them. Typically, when you're collecting your data, you're probably going to have it in some kind of a database. So the CTSC typically advocates using REDCap, which is a database that really is very secure to house the data. But you can almost also think of it in terms of just an Excel file, kind of in the simplest case, where how do you organize your data? So you want to avoid language such as, here's my data file. I'd like you to look at column AE and correlate it with something else. That's not very useful to the statistician. You really want to have a very well-defined data dictionary, where clearly once you have all your data collected, everything's defined. You have a definition of all the variables in your data file. They're all going to have different values. What do the categories represent? So if it's a continuous variable like blood pressure, what's the potential range for blood pressure in your data set? If it's a categorical variable like like a comorbidity score, what are the categories of that score? Or if you're looking at educational level as a variable, file might just have it recorded as 1, 2, 3, or 4, but you want to make sure that somewhere it's written down, high school, college, graduate school, things like that. So that's what they call a data dictionary. Typically with REDCap, which is again the CTSC's database for housing data, it kind of forces you to have a data dictionary, which is very good to have. You want to avoid ambiguity in terms of how you collect the data. So when you're entering your data into a file for research purposes, you want to be consistent. So if you're looking at the date of a surgery, for example, you want to record it consistently the same way each time. You don't want to have mixed date formats in your file. You also want to avoid things like free text. So, sorry, if you're looking at the result of some kind of a test where it's negative or positive, you want to just enter that very clearly. So, 0, 0 negative, different spellings. These are all, if you have it like this in a file, it's going to make it very hard to analyze the data. But typically, we advise clinicians, researchers to kind of put everything into the file numerically with codes, and then have a data dictionary to kind of map it. So you don't want to have things like where you're just having different spellings and things like that. Because in this example here, we're just trying to look at negative, for example, but there's all these different spellings in the file. So often a researcher will be entering things in a file like Excel, really for themselves, more visual visual kind of collecting the data, but the data you ultimately turn over to the statistician obviously has to be much more. So there's basic rules for a data set. Every variable should have its own column in the file. Each observation should have its own row. An observation would typically be a patient, individual patients. Each value in the file should have its own cell. Classic Excel file type example. You want to avoid things like highlighting. So in your Excel file, when you're collecting your data, you ideally should have it on one sheet in the file. You don't want to have multiple sheets where sheet 1 is like patient 1, sheet 2 is patient 2. You want to have it all in one file. Many times investigators will collect data, put it in Excel, and then they'll be kind of running their own calculations in the Excel file itself, and they'll have like some graphs in there, and they'll have different things highlighted. That is not useful to the statistician because we bring it into a different program to analyze the data. So when you have kind of this mixed bag of things in the file, it makes it very difficult to look at. So typically a statistician will send that file back to you and they'll tell you to reorganize it in a much cleaner way. Or if your data is in REDCap to begin with, it's much easier because when they export the data from REDCap, it's already in a format that's clean for the statistician. So here's an example. Somebody might be collecting data. They have this condition variable, which has 3 levels, 1, 2, and 3. They're also collecting path size, let's say on a tumor, and they're also saying right or left. We just kind of have it all entered into this thing on the left, and they have like highlighting going on. You can't really bring that file on the left into any kind of statistics program. Statistics programs that are commonly used are like SAS, R, Stata. You might hear those a lot. So typically you'd have to reformat. So as you move over to the right, you'll see one column for condition where it's just repeated 1, 1, 1, 2, 2, 2, and so forth. And right or left is separated out with its own column. And path size, which is a numeric variable on a continuum, is its own column. So if I wanted to calculate the mean path size, I can easily do it on that third column on the right there. Whereas on the left picture, I can't, if I were to run a program to try to calculate the mean tumor size, mean path size, I can't do it because that column has text in it, the L's and the dashes and things like that. So you want to keep that all separate. And even in the picture on the right, with the column that says right or left there, you really probably want to use a code for that. You probably want to say 0 is right, 1 is left, and then just have 0, 1 in that column, and then have a data dictionary that tells you that 0 means right, 1 means left. Because many programs we use in statistics need to have numeric type data for the analysis. So a lot of the cleaning will happen up front. If you rely on the statistician to do it for you, it can be more costly because if the statistician is charging you or they have a certain salary allocation to the department that you're working with, it takes much more time to clean the data. So it's kind of better to have it all done up front in a clean way. So these are really just some tips about how to collect your data. When you send the data over to the statistician, you want to make sure you remove all the possible HIPAA identifiers. These are the 18 common ones that you can look at. So obviously, name, address, any kind of patient identifiers should be removed from the file. You might have a file that has all that information, obviously, as the clinician or as the researcher. But once you turn it over to a statistician, or a different type of analyst, or whoever it might be, you want to make sure you remove a lot of that information. So then again, how do you collect your data? What's the sample you're looking at? And that typically will dictate the types of inferences you can make. So what's the clinical population you're going to be studying? How do you collect that data? It's a sample from a larger population, presumably. Where do you get that sample? Are there any logistical constraints in collecting the sample itself? So the different types of sampling that we talk about in statistics. So everything in statistics is basically you have a population of interest. Let's say all diabetics in a certain state, let's say, but you can't look at everybody in the state. So you're going to work with sampling. So different types of sampling strategies. Simple random sampling is where you have a population of interest and you randomly sample from that population to get the patients for your study. But every participant in the population has an equal chance of getting into your study. Very uncommon because most research obviously is done in hospitals, clinic settings. It's not really going to be random. But that's the concept of simple random sampling. You can do it. Stratified random sampling is more common, where you might have a population of interest, but it's broken into categories up front. So maybe you're separating, men from women. Maybe you're separating based on ethnicity or race. They call that strata. So you might have kind of buckets of people in the population that are like strata 1, strata 2, strata 3. And then theoretically, you could randomly sample from within those categories. You might ask, why not just use everybody in the population? But you can't because it's too expensive to look at all those people. So everything in statistics tends to take samples from an underlying population. So any individual clinic-based study, hospital-based study is theoretically a sample from a larger underlying population. So if I'm looking at a specific type of surgery conducted at Cornell, in the neurosurgery department, I'm looking at their neurosurgical patients. And let's say there's 100 patients that have a very specific type of surgery, and I want to see how well they do. Presumably that group of patients is a sample from an underlying population of all people that could have possibly gotten that surgery in a larger population of interest. So these are kind of loose rules. The theory is that it's random or that you have an underlying population, but you can think of any research study as a sample from an underlying population. Cluster sampling is also pretty common where you might just be looking at one specific school, for example. Maybe you're looking at one school in New York City and you're going to look at the students in that school, and that's going to be your study. That's called a cluster because the school represents the cluster. So by no means is it random. You're not looking at a random sample of children from New York City. You're focusing on one school, which already has a number of characteristics about it, depending where it is. And then from that group, you're taking a sample of people from that cluster. So these are different types of sampling you might read about. Typically, the biggest thing a researcher will ask a statistician is, how many patients do I need to have in my study? And that really depends on what you're looking at. So many people will come in and say, how many patients do I need for my result to be statistically significant, right? How many patients do I need for me to be able to detect to get a p-value? If you're reading the literature, p-value less than 0.05 means you have a statistically significant result, which we'll talk about a little bit later. So that's not enough. You need to bring a lot more information to the table when you meet with the statistician to really be able to know, the statistician to be able to tell you the type of sample size that's needed. So sometimes sample size will be fixed due to logistics. So the researcher comes and says, I have 40 patients that I'm studying. That's all I have available to me because those are the 40 patients that were in the hospital at this point in time that have this treatment. That's a fixed sample size. So in that case, we work backwards to find out, what can you detect with those 40 patients? So we're trying to measure the effect of the treatment. Is the treatment beneficial? That's often based on your sample size in terms of your ability to be able to find if the treatment works. But we can work backwards to figure out what kind of power, they call it, that you had for detecting the difference. So power is basically a word that simply means, if a treatment actually works, the treatment could actually, let's say, lower your blood pressure. A new treatment can lower your blood pressure, let's say more than a standard treatment. If it really works, the power of your study is your ability to be able to find that difference. If that difference is real, are you adequately powered to detect it? And that is driven by sample size. The smaller your sample size, the less likely you'll be able to find differences. The bigger your sample size, you have more power in your study. So here's some examples. So, we can think of it as two different categories. Questions of description would be a researcher where they're doing a study, but they're not really comparing one group to another. I'm not comparing treatment A versus B, or I'm not going to compare men versus women, or I'm not going to compare surgery 1 versus surgery 2. We're really just going to be doing a study. Maybe I'm looking at 100 diabetics, and I want to measure the prevalence of high cholesterol in those diabetics. So it's one sample size, one group of patients, but I'm not really comparing. But when you're writing up your protocol, the Protocol Review Monitoring Committee, called PRMC at Cornell, or the IRB, typically the science review committees come first. Then once they get approved, the study is approved, then the IRB looks at it. But the Protocol Review Monitoring Committee typically looks at science, statistics, and feasibility. So they're often going to say to you, justify your sample size. If you have 40 patients, why 40 patients? Or why are you only looking at 100 patients? You need to be able to tell the reader, the reviewer, some justification for your sample size. The easiest way to do that when it's a question of description, meaning we're just going to describe some proportion in that population, like the prevalence of high cholesterol in a group of diabetics, for example. you can justify your sample size based on how much precision you'll have around the estimate you're measuring. So for example, let's say the clinician or the researcher says, I plan to prospectively collect data on about 200 consecutive intensive care unit admissions. So that they're telling you up front, my sample size is 200. Maybe that's all that's available to them. I also expect that about 15% of these patients will develop delirium during their stay based on prior literature. So their outcome of interest in this study is delirium, the incidence or the prevalence of delirium in these types of patients that are being seen in the ICU. So that the ICU is your population of interest. Your outcome variable is, the incidence of delirium. There really isn't any exposure variable. We're not really comparing groups, risk factor 1 versus risk factor 2. We're just looking at one group. We're just going to measure the incidence or the rate of delirium in that population. The protocol review monitoring committee will say to you, why 200? Is that enough to really adequately measure or estimate the incidence of delirium in this population? So a statistician will say things like this to you. They'll say, well, we'll run a calculation, and they'll say with 200 patients in your sample, a 95% confidence interval, which is essentially a range of precision, but the proportion of patients who develop delirium, which is your outcome, within the ICU, can be constructed to be within plus or minus 4.9% of the observed delirium proportion. So if in reality, at the end of the day, the incidence of delirium in this population really is 15%, that's what they call a point estimate in your study. The plus or minus 4.9% is your range of precision around it. So it's kind of saying somewhere between 11% and 19%, we expect the prevalence or the incidence of delirium to be. You maybe it was 15% in your one study, but here's a level of precision around it. The smaller your sample size, the wider your range is going to be. So if you have only 20 patients in your study, that plus or minus 4.9% will be much bigger. It'll be like plus or minus 20%. Because the less patients you have in your study, the less precision you have. Smaller sample size means less precision. The review committee won't reject the study based on that, but at least you're saying up front, how much precision can I get with X number of patients? And that's a way to kind of justify your sample size. So even if you only have 30 patients, you're still telling them, yeah, it's not very precise. I'm going to have a very wide confidence interval, but it's preliminary data. It's a pilot study. Those are terms you can use when you're writing up your justifications. But the statistician can provide this information to you in terms of an exact sentence to put into your protocol. So for questions of comparison, which are probably easier to understand, that's when you're actually literally comparing, like in a clinical trial, treatment A versus treatment B, for example. In that case, you kind of need more information. You need to know, clinician or the researcher needs to know, what is the hypothesized difference you're looking for? And you have to kind of bring that to the table. So what's the minimal detectable difference of the outcome between groups that you want to measure? So for example, if my goal is to look at a new treatment to lower cholesterol, then let's say I have a standard treatment versus a new treatment. If I know the standard treatment at the end of, let's say, 4 months post-treatment, I think the cholesterol will be around 200, let's just say. And maybe I want to reduce it with the new treatment, but by how much? And reduce it by 10 points on average, bring it from 200 to 150, 200 to 180. You kind of have to specify what's the difference that would be worth measuring. What's the minimal detectable difference that would make it worth to pursue this new drug? Is it a 20-point difference, a 10-point difference? You kind of need to bring those estimates to the table. And typically you get them from the literature. Sometimes it's kind of guesswork where you're just postulating how much you think this new treatment could lower cholesterol. So here's an example. An investigator says they anticipate retrospectively collecting about 500 patients. So they're already actually collected. They're somewhere in a repository somewhere. We know that about 70% of them have this polybenzization allergy, and the other 30% have a monoallergy. They kind of have this breakdown. They're looking at the incidence of persistent asthmatics. So their outcome is being an asthmatic. Their exposure is the type of allergy they have. And they want to be able to detect a meaningful clinically difference between the groups. And they're actually being very specific. They're saying a 13% difference in the proportion of persistent asthmatics is a minimal clinical meaningful difference they'd like to be able to detect between the groups. So you can translate that. If you read further down, for example, let's say in the In the mono group, let's say the incidence of persistent asthmatics is 57%. The next group over is 70%. So that's the 13% difference. They're saying if I have these two rates for persistent asthmatics, that difference of 13%, how many patients do I need to be able to detect it? So here, the statistician will run a calculation, and they're saying with about 350 patients, 350 in the poly group and 150 in the mono group. The reason why they're not equal is because the poly group is more common. 70% have it, 30% don't. So 350 and 150 in each of those two groups, respectively. A chi-square test, which is a standard statistical test for comparing proportions, will have 80% power to detect a 13% difference between the two groups, assuming these are the proportions I'm looking at, assuming that we think one group will be 57%, the other group will be 7%. 80% power means is a common benchmark we use. So most agencies will want you to have at least 80% power in your study. Power simply means if this difference is real, if these two groups really will, if they really do differ in terms of how many people become persistent asthmatics, your study has an 80% chance of detecting. That also implies there's a 20% chance your study will miss it. But you want to at least have 80% power. You want to have more power, but the more power you want, the bigger your sample size has to be. So a classic sample size calculation that a statistician will provide to a researcher for like a two-group study is something like this. How many do you need per group? How much power do you have? You want to have at least 80% power. But that 13% that's in the paragraph there comes from the researcher. They have to bring that to the statistician and say, to us, a 13% or greater difference is worth detecting. It could have said 10%, it could have said 5%. But the smaller the difference they're looking for, the more patients they're going to need in the study. So that difference comes from, that's their hypothesis. That's what they're postulating. That's what they think the difference will be. That kind of needs to be put into the equation. So the statistician cannot just come up with a magical number and just say you need 500 patients total and you'll have a great study and you'll find a significant result. It really depends on the actual inputs to that calculation doing here. So statisticians typically will draft, if you're working with them from the very beginning, they will draft, with the protocol, they'll draft the statistical analysis plan for your protocol. So number one, they'll do the sample size power calculation. So you'll meet with them. They will tell you how many patients you need. They'll ask you many questions. Like we said, what are you trying to detect? What's your endpoint? How many groups are you comparing? Once you know all that, and the statistician knows, they'll run this calculation, and they'll draft up this paragraph, like on the previous slide, the one in the middle. They will typically take that paragraph and they'll place it into the protocol. And they'll also have a statistical analysis plan that goes with it. That plan just basically tells you how will you analyze the data. So if you're comparing two groups, what types of statistical tests will you use? So when you read the literature, you see things like t-test, ANOVA test, chi-square test. Those are all common statistical tests that really are used based on how your data is collected. If you're involving a statistician from the beginning, they will stay with you throughout the study. Once the study is completed and the data is collected, they will actually carry out the analysis for you. So many of our statisticians in the Division of Biostatistics at Cornell are actually placed within certain departments. So if person number X is working 30% of the time with neurology, they will work on those projects from beginning to end, do the analyses, and also help write the paper, draft the manuscript. The statistician typically is always a co-author on the paper. For anything that comes with the CTSC, we kind of mandate that the statistician be involved or be an author on the paper, because we typically link the effort to the CTSC grant. So we'll cite the CTSC grant number in the manuscript. Paul's effort on the paper was supported or funded by the CTSC. So these are all the things that are commonly used in the deliverables that a statistician would give back to the investigator. In terms of deadlines, when you're meeting with a statistician, you want to obviously keep in mind, so what's the IRB submission deadline? What's your abstract deadline? Many investigators will come last minute and say they want to submit an abstract that's due next Wednesday at 11:59 p.m. Maybe they have the data collected already. They want us to analyze it, but they expect it to be done like within 2 days, which is impossible. So you want to, if you're meeting with a statistician, certainly for data that's already collected, you just need to have it analyzed. You want to give it a lot of time, like at least a couple of weeks to so there's adequate time to analyze the data. Also, manuscript resubmission. You submit a manuscript, it's not rejected, but they ask you to revise it. Typically, the authors, the primary author, will come back to the statistician if they had one from the beginning, and ask them to redo the analysis, help us respond to the reviewers for the paper. That all takes time. So you want to keep in mind the deadlines that you're seeing here for the IRB, for the abstracts, for the manuscripts, and so on. So you want to give ample lead time to the statistician because they're working on many different things. They're not just working on your project. They could be assigned to many different clinical departments, academic departments, and doing a lot of different projects. So when you're working with them from the beginning, you want to keep communicating. So you have the initial meeting with the statistician, but there's going to be a lot of back and forth because you're going to work with them throughout. Don't hesitate to ask questions if you're unclear what the statistician is presenting to you. Typically, the statisticians are trained to give their reports, explain to clinicians or clinical investigators, explain the results in lay terms, because many people are not going to know how to interpret certain statistics. So, but the statistician will often reach out to the researcher as well for more clarification on the other side. You want to have this back and forth communication between statistician and the researcher, the primary investigator on the research study. Again, some statisticians will have stronger backgrounds in the subject matter, in the clinical subject matter than others. So you want to kind of keep that in mind and kind of adapt your communication to help the statistician understand. So it's always good if you're having meetings with a statistician to summarize the meeting, take notes, come to the meeting with very clear aims. Many times investigators will come in and they don't really have a clear research question. They don't really know what they're ultimately going to measure. And having that up front is much more useful to have a more constructive meeting. But if not, the statistician will help you kind of define those terms. So the best collaborations typically happen when you obviously have effective communication between the statistician and the investigator from the beginning. You want to have patience, respect for each other's knowledge base, and so forth, ideally. Again, this is kind of pie in the sky a little bit because many times statisticians are brought in, towards the end of a study, middle of a study. The ideal situation is to have them from the beginning. But in terms of statistical consulting, think of it that way, the data might already be collected and you're just asking the statistician to analyze it. So you have this kind of different scenarios that might happen. Common statistical tests, just to be aware of when you're reading protocol. So I see in the course, you have a section on reading a grant proposal, things like that. These are the common terms you want to be aware of, the common tests that you want to be aware of. So like we talked about earlier, ability to find the exposure, what's your outcome, what's the population of interest, and the test that you choose, the statistical test you choose to analyze your data, typically is based on how these variables are defined. How is the exposure measured? How's the outcome? So you've probably all seen the types of tests that I'll just briefly go over. But in terms of your variables, are you looking at a continuous outcome like cholesterol or blood pressure? Is it an ordinal outcome like a Likert scale 1, 2, 3, 4, 5, or a pain scale that goes from like 1 to 5 or 1 to 10? It's not really continuous. Categorical outcomes, did they survive or not? Did the breast cancer recur, yes or no? And then multivariable analysis. Are you doing some kind of a multivariable model? These are all terms you're going to see a lot in the literature. So this is just a couple slides on the common types of tests you're going to see. So when you're reading a proposal or a grant proposal, if there's a stat section in that proposal, and there should be when you're reading it, these are the things you're probably going to see in that proposal. Let's say the outcome of interest is a continuous variable, such as cholesterol, BMI. Maybe it's just like a knee rating scale that goes from like 1 to 100. So it's still we would still call that a continuous metric because it goes from 1 to 100. Hamilton's depression score kind of goes from like, 0 or 1 to 31, 1 to 30, whatever it might be. So that's still what we would call a continuous variable. So if I'm comparing groups, I'm comparing treatment A versus treatment B, the classic test you would do would be the two-sample t-test, which is used for comparing two independent groups, like treatment A versus treatment B. And what does it compare? It compares the mean. So the t-test compares the mean value between the groups. So for the end of the day, I'm looking at a depression score, and I want to see if one group is doing better in terms of lowering depression. I'm going to look at the mean depression score in group 1 and compare it to the mean score in group 2. The two-sample t-test is the common test you would use for that. So it's whenever you're comparing two groups, basically. The paired t-test is very specific. That's when you have like a before and after experiment where you might only have one group of patients, but you're measuring something before, then you kind of give them the intervention, then you see how they do after. So, you might evaluate the patient before surgery in terms of their pain, then you might evaluate them after surgery in terms of their pain. And at the end of the day, maybe pain is measured on a scale like from 1 to 100, and you're going to have a mean pain score. You're going to have the mean pain score, prior to surgery, the mean pain score after surgery on the same patient. And the paired t-test would be the test that you would use for that. So these are really just the common tests you're going to see a lot in the literature. The ANOVA test stands for analysis of variance. That also looks at the difference in mean values between groups, but it's when you have more than 2 groups, like 3 groups, for example. So, what's the mean cholesterol at 6 months in group that got treatment 1 versus treatment 2 versus treatment 3? I want to see if their cholesterol went down. So I'm going to report the mean cholesterol across the 3 groups. If I want to know whether or not those groups are quote unquote statistically different, you would do an ANOVA test. So these are all essentially tests on this slide that are comparing mean values, which is why the last line of the slide there says tests are actually comparing means between groups. If your outcome variable is not really continuous and it's classically ordinal, like a grade 2 NCL tear, pain score that goes from 1 to 5, a Likert scale variable that goes from 1 to 5, for example. Many times the reviewer, if you're writing this up for a paper or a manuscript, they're going to say to you, well, you really shouldn't be doing t-tests or ANOVA tests. You should be doing what they call non-parametric tests, meaning that if your data really is not continuous, doesn't really follow a bell-shaped curve that you see a lot in the literature or in statistics. Non-parametric tests are a different set of tests that are used when your outcome variables are not really truly continuous. So these are kind of equivalents to the ones we just saw on the previous slide. So, in the previous slide, the 2-sample t-test is very common to use. The equivalent to that in the non-parametric world is called the Wilcoxon rank sum test. It's still comparing 2 groups, but instead of comparing the mean between the groups, it typically compares the median. Because oftentimes you might have a variable that's skewed. So, like things like income, for example. They usually report median income. They usually report median length of stay in a hospital. They don't report like mean income or mean length of stay. And that happens because length of stay, for example, tends to be skewed to the right, where you have some number of patients that have very long length of stays in the hospital. So if I were to use the mean, it gets pulled up. It's not really accurate because it's very susceptible to those outliers. The median in that case would be more representative. So the rank sum test, and these are just kind of names you have to be aware of, is a test that actually compares the medians, and it's called a non-parametric test because it does not have any assumptions like you have a bell-shaped curve or anything like that. The sign rank test is the equivalent to the paired t-test if you're comparing patients before and after a surgery. But again, your outcome is like ordinal, it's not really continuous. So maybe using a mean is not valid. Likewise, these tests are used if your sample is small. You only have like 10 people in your study. Typically, any journal is going to say you should be doing these types of tests. You should not be doing the ones on the previous slide because these tests really work best when your sample size is bigger, 25 or more, or your outcome is truly continuous, meaning it has a wide range of values. But if your outcome is more categorical or Likert, like we have here, these are the types of tests you would more commonly use. The Kruskal-Wallis test is identical to the ANOVA test on the previous slide, if you want to compare more than 2 groups. But again, it's reserved for the situation where your outcome is potentially ordinal, where a median is better to use than a mean. So we don't really have much time to get into the stats behind all of this, but these are just some of the common tests I want to make you aware of. So these tests above compare medians between the groups. It turns out, however, though, that the parametric tests, which are the tests that are more commonly used, t-test, paired t-test, and ANOVA, tend to work well even with ordinal data. So even though technically you should use the test on this slide when your data is more ordinal or your sample size is small, you tend to get very consistent results. Even if you did the test on the previous slide, quote unquote, incorrectly, you're still going to get almost the same answer. So the previous slide, these tests are pretty, the word is robust. In other words, even if you have violations in your data in the sense that they're not really applicable to using these types of tests. These types of tests will still give you more or less, more often than not, you still get the right answer with these tests. But again, you want to use the correct test, but just to be aware, generally you'll get consistent results. So again, parametric test just means the common ones that we see, t-test, ANOVA. Non-parametric tests are more for when you have smaller sample sizes where your outcome variables are, like I said, ordinal. Then you have classic categorical outcomes where, like mortality, yes or no, injury status. Maybe you have a pain score that's in very specific categories, like 1 to 3 versus 4 to 5 versus more than 5. So that's a truly categorical variable, slightly ordinal too, because 1 to 3 is lower than 4 to 5. But when you only have 3 categories, you're really making it an actual categorical variable. In that case, the chi-square test is the test typically we would use. Again, these are just names to be aware of. If I wanted to compare more than 2 groups, the chi-square test is typically used. Fish's exact test is also used in this setting, but when you have really small numbers, it's really the same exact test. So if you look down at the tables below, age of diagnosis there on the left has been broken into 2 categories, less than 46, more than 46. Then I'm looking at surgery. I think this is breast conservation surgery versus maybe mastectomy, I can't remember, but 2 different types of surgery. And really what a chi-square test will do will simply say, if you're in the less than 46 group, are you, more likely to have 1 surgery versus not, things like that. So when you have these categorical row by column tables, like in these 2 pictures here, that typically means you're going to be doing the chi-square test. 2 rows, 2 columns, that's your classic kind of, row by column table that the chi-square test would be used. If the numbers are really tiny, like the table on the left, you'll see there's only 3 people, 2 people, 2 people, very small sample size. In general, the Fisher's exact test would be used in that picture. Look at the association between age and surgery. Whereas the picture on the right, you have a lot more people, 33, 24, 12, and 50. That's a bigger study. The chi-square test could be used there because you have more decent numbers in your study. And the percentages there, the in parentheses are just the percents within the category. Other ways you'll see in the literature in terms of how things are measured, in terms of outcome and exposure. You might have seen studies with cohort designs, case control designs, for example. So just a quick example. Let's say you're looking at incidence for coronary heart disease, and you're comparing smokers versus non-smokers. This might be a classic cohort study where I'm following 3,000 smokers, which you can see 3,000 over there on the right, and I'm comparing it to 5,000 non-smokers. And let's say you follow those people over time. Let's say it's like a 5-year study, for example, and 84 of the smokers, 84 out of 3,000 smokers got heart disease, 2,916 didn't. In the non-smoking group, 87 got heart disease, 4,913 didn't. So you have basically in those 2 rows, what you have there is the incidence of heart disease in smokers, and then you have the incidence of heart disease among non-smokers. So this is also a 2x2 table, 2 rows, 2 columns. If I wanted to know whether or not I have a statistically significant association here, I would do a chi-square test because these are categorical variables, binary variables on both sides. So how would you write that up in your study? So you kind of word it as the rate. So in the smoking group, 84 out of 3,000 got heart disease. So that would be about a 2.8% incidence of heart disease. You can leave it like that. Sometimes you'll see it expressed as 28 cases of heart disease per 1,000 people per year kind of thing. But more often than not, you'll see it as a percentage. In the non-smoking group, only 1.74% had heart disease over time. So, is that different? For example, these are pretty rare outcomes, but is 2.8% meaningfully different from 1.7%? You might say no, because it's a pretty small difference. But, is that difference real or is it just due to chance? That's kind of what the p-value ultimately is. So typically in a study like this, they express it as a relative risk. If I just took the ratio of those 2 incidence rates, the relative risk would be 1.6. That tells me that if you're a smoker, you're 1.6 times more likely to get heart disease compared to being a non-smoker. Another way of wording it would be smokers were 60% more likely to develop heart disease compared to non-smokers. This is just a ratio of the two incidence rates. I'm really literally just comparing, 2.8% to 1.74%. If I take the ratio, that gives me 1.6. If I want to know whether this is statistically significant or not, that's a different question. So statistical significance means, if there truly was no relationship between smoking and heart disease, if there truly was no relationship between smoking and heart disease, how likely is it that I would get these differences? How likely is it that I would see a difference of 1.74 versus 2.8? The p-value, which we're not obviously focusing too much on today, tells you the likelihood that this difference is due to chance, or could it be real? And that's what p less than 0.05 means. P less than 0.05, which you see a lot in the articles, means that if there really was no difference between smokers and non-smokers in terms of heart disease, the likelihood you would see this happening is less than 5%. So that's kind of where the p-value is. The relative risk is it's commonly used. Relative risk of 1 just implies something's happening. Relative risk more than 1 implies there's an increased risk. If you have the exposure, less than 1 means you have a decrease. And then lastly, multivariable analysis. Typically, any study you're reading, any grant proposal you're reading, at some point is going to talk about, yes, we're going to do a t-test. Yes, we're going to do a chi-square test. But ultimately, they're going to say at the end, they're also going to do multivariable modeling of some kind. So, for example, maybe their research question is, what predicts ACL reconstructions to fail? So their outcome variable there might be, did your ACL reconstruction fail, yes or no? That's their outcome. And let's say type of surgery is their primary exposure of interest. Then maybe if I have surgery 1 versus surgery 2 versus surgery 3, which one does better in terms of how well my ACL reconstruction works? So my outcome is, does it fail or not? And maybe my primary variable of interest is, does the type of surgery influence that failure rate? However, I want to control for other variables. I want to take into account age. I want to take into account gender. I want to take into account graft source, rehabilitation. Is the patient also getting rehabilitation? What's the extent of the injury? These are what they would call potential confounders. So typically what a multivariable analysis will do is it looks at all these variables simultaneously in the model. So my outcome is still, did the ACL reconstruction fail, yes or no? But these are the predictors in the model. It's always good to have a primary predictor of interest. So when you're writing up your protocol, your primary aim would say, does the type of surgery you receive impact your ACL reconstruction failure rate? However, I also want to look at the effect of graft source, rehabilitation, injury, or I want to control for those. Essentially, you'd have all these variables would be entered into a multivariable model. So you're going to see that typically at the end of a stats section of protocol. You're going to say, at the end of the day, we're also going to do a multivariable model. The type of model is based on how, again, the variables are measured. So if your outcome is a continuous outcome, like a pain scale that goes from 1 to 100, or cholesterol level or blood pressure, multivariable linear regression is typically used. So if your outcome is continuous, that's the easiest way to remember it. You have a continuous outcome, and you want to look at many different predictors, you're going to use a multivariable linear regression. If your outcome is binary, which we actually just had in the previous example, does your ACL reconstruction fail, yes or no? It's a binary outcome. You would use something called multivariable logistic regression. So no matter what article you're reading, you're probably going to see at some point one of these terms. So that just means your outcome is binary. But again, you want to look at the effect of many variables, not just one variable. So when we think of t-test or chi-square test or ANOVA test, we're really thinking of one variable. Are you in group A, group B, or group C? Once you get into the multivariable world, you're adding in other variables simultaneously. If you're looking at survival analysis, when you see Kaplan-Meier survival curves in the literature, any kind of multivariable model for that type of data is called Cox proportional hazards regression. Again, just be aware of the terms, the names. So this is very specific to survival analysis. So any study looking at 5-year survival for cancer, for lung cancer, or if they're comparing overall survival between treatment A and treatment B, once they get into the multivariable world, they're going to be doing this type of regression. So it's very specific to survival. These are really the only 3 you're ever going to see. There are definitely more fancy ones like mixed models, generalized estimating models that are for like longitudinal data measured over time. You'll see those as well, but these are the big three you typically will see in most papers. So typically the way it works in my division, and I'll stop there, is for the CTSC, there is a form that investigators can fill out, which is a console form. They typically describe their study. This is the link. And it comes to us that typically in my department, we assign a statistician to work with that investigator. The resources are obviously limited because we offer about 6 or 7 kind of free hours to the investigator, which could encompass both writing up the protocol, the analysis plan, or actually analyzing data. But it's hard because there's not much funding. Again, most of our statisticians are actually working with departments and partially funded by that department. But we do have a mechanism through the BIRD core that I was talking about, for the junior investigators that don't have funding, just submit this consult form, and then we can help them with the study. And even if it goes more than 6 hours, we typically still do it because we want the CTSC to be productive. So if a researcher's project ultimately makes it all the way up to a manuscript in a peer-reviewed journal, that's great. And typically that helps the CTSC because we're showing what we're able to help the junior investigators. So this is a link just to have, if you ever have a research study and you want to reach out, you can just fill this out. It comes directly to me, or you can just email me directly, and we can assist you with your study. We have about 13 or 14 master's level biostatisticians that can work on projects. And we have faculty as well, obviously, but they may not work on the individual projects as much, but they have the resources to help out. So I think I will stop there. We're ending at 3:30, right? Yeah. So let's, anyone feel free, questions, 10 minutes or so. Thank you.
Yeah, I know that was a heavy
that was a bit heavy.
dose
of math. Yeah, you can maybe share those slides with them.
Okay, yeah, sounds great. I'll share it with the recording. But
do we have any questions?
Yeah, I'm available for questions. Feel free to.
Oh wow!
I know it was a lot.
Yeah.
Yeah.
It's a lot, but
speechless. You have to like rewatch the video and go through the slides again.
Yeah, and we weren't really trying to emphasize in any way how to do the calculation. It's really just the terminology, just to be aware. And the main point really is just, if you're doing a research study, main point to take home is contact us right away from the beginning, so we can help you collect your data, design the database, tell you how to best measure your outcome. You know your discipline very well, obviously, but it's good to meet with the statistician to figure out the best way to analyze the study to help you really write the protocol. That's really what it comes down to. Because a lot of writing the protocol is defining your primary endpoint, your primary objective, having an analysis plan, having a sample size calculation in your proposal. That all needs to go in there before you can submit it to the PRMC, and not just Cornell, go for anywhere. So it's always good to involve us. So it's a resource that's available to you. As members participating within the CTSC, you can contact us.
Yeah, for me, I think when going through a presentation like this, it's easier when it's applicable to something that I'm doing, or I can like relate it to something that I could, as an example, maybe. So maybe for next time we can like, I don't know. I'm just thinking.
Yeah, you could pick one of the studies you might be working on. Yeah, and we could use that as a model, and then kind of go through what you think. What's your best endpoint? What are you measuring?
I think it was very good. I think about my classes in Lehman with statistics, and I think about the 2 or 3 research professors that I'm still in contact with for many years now.
Yeah.
So yeah, so it's a nice. It was more in depth and more details and a whole lot of additional new information. But to see how you tied it all in, it really brought some of that stuff to life for me. So I definitely appreciate it. Yeah.
Sure. Yeah. And again, it's a core.
I mean, the only thing I remember is that SPS stuff. SPS,
yes, SPS. Yeah. I still use that program sometimes. Yeah. So it's just good to have.
What version are they? What version are they up to now?
Oh my God, SPSS I believe is up to version 26.
Yeah, I could talk about 9 or 10.
9 and 10. Like yeah. And so many other programs are more popular now, but you'll see there's like a smattering of like 3 or 4 major programs. But again, the BIRD core is a core within the CTSC that is here for that purpose, to help investigators, conduct their research and do the analysis. So by no means are you expected to do your own analysis. It's to meet with the statistician to kind of walk through it. Thanks.
Well, you know something, Paul, this is Lula May. One of the
Yeah.
things that I'm going to, like when community groups or our partner community groups, and when they start to work on projects, I'm going to have them get in touch with you because I'm talking to a church group and they're interested in doing something on Similac and Infamil.
Mhm.
And so, you know something, I'm going to have them after they get a few, after they get a clear objective, they come to a general consensus of what they think they want to do. I'm going to let them talk to you.
Sounds good. Yeah.
Okay.
Yeah. And I think when you have that last session where you're reviewing the grant proposal, you'll see a lot. I'm not sure what you're going to give them to look at, but typically you'll see these types of terminologies in there. So it's kind of good to have that background.
Yeah. So thank you so much.
Sure,
Paul.
no problem.
Thank you.
Yeah, feel free to email me any questions after the fact. That's fine too. Thanks.
Okay. Yeah, I will send everybody the recording and questions we'll have ready for next week, but I'll send the slides and the recording.
Okay,
If not today,
Thank you.
then next Monday.
sounds good. Okay, thank you for attending. Take care, everybody.
Thank you.
Thank
Bye-bye.
you. Thank you
Bye.
so very much.
No problem.
Lula,
This
did you
is
want to discuss the
photo novella? Yes. Are there any questions? Anybody has any questions, concerns, ideas about their photo novella project they'd like to talk about today?
I don't know, but I finally got one, and it's kind of exciting seeing the people, not exciting, but interesting to see the individuals who are, I call it hanging out in those, in the bank lobbies for either for sleeping or whatever. So right now I'm like in my vehicle taking pictures of them from the back. Eventually I'm gonna get some close up, but it's very interesting to see the people that are just hanging out. I mean, they come in there, they got milk crates and everything. They got like a whole setup.
Oh, yeah,
And
you're
thinking
right.
about, and how it impacts people who's coming in to get their money, how they're fearful. Sometimes it's the odor, but you're trying to stay out of the weather, the fear of wanting to be in any kind of shelter. At least you can feel like you can control that particular environment. But I already took like 3 shots, so I'm just thinking about how I'm gonna get more in depth with that. But it's pretty interesting.
Oh, okay. Do you think it has anything to do with our mental health issues currently?
Oh no, it's definitely. I mean, some people are pretty strong, but it's the fear factors that keeps them away from getting help. We like to have our independence and control. When you get involved with a shelter system and so on and so forth, you have to give up that mobile card. You have to give up that bag and things that you feel comfortable. Today I just seen an individual by herself, a young lady. Then the night before it was a young lady and a man. And, they like made up like a nice little camp and so on and so forth. But I believe people that do know that there's resources that exist, but you're going to give up a lot. As for some people, it's just not worth giving that up. That independence, that control of coming and going, and so it's a tough balance.
Oh, okay. All right. Sounds like a great project. Great photo novella.
Now, there's other thing you talk about. I don't know what that is yet, but I guess I'll figure it out. So, the voice one. I don't know what. I have to look over that a little bit more.
Oh, okay. Okay. Basically, it's the same thing.
Okay.
Same thing. Basically, it's the same thing. Oh, you're welcome. Thank you. Anyone else have a question? And the other thing is, I want you guys to get prepared so that perhaps you'd like to get involved in presenting this information with Dr. Elizabeth Cohen at a meeting that's held. I don't remember the exact title of the meeting, but it's all about photo voice, photo novella, or it's all about making your voice heard in the political arena, in the social arena, and how it impacts others.
Yeah, the
So
community engagement conference.
Yes, community engagement conference, right. Thank you, Agnes.
You're welcome.
Reverend Lula May, this is Sheila.
Yes.
Okay, I had done one, but it was short. Are you asking for another one?
No. If you're satisfied with the one you've done, fine. If you want to add something else to it, go ahead. If you want to leave it the way it is, fine.
You can add, tweak, but I think Dr. Cohen is just taking the ones with the ones with the updated assignment to use for the conference, since it's a new
Yeah, a new
yeah,
view.
new
Yeah.
questions.
Yeah.
Okay.
So if you want to tweak the one that you have, that you submitted, you could resubmit it and add more information about trust, or, you know, so that it fits the criteria, her new criteria.
Okay.
Okay, thank you.
I'll probably do another one.
Awesome.
Okay. Okay, great.
The more the
All
merrier.
right. You are right about that. So leave that one, Sheila, and submit another one.
Okay.
Okay.
Okay.